I had the honor to meet at the American Academy of Medical Acupuncture course or to attend his presentations, Dr. William Clearfield. Dr. Bill Clearfield, a 1978 graduate of the College of Osteopathic Medicine and Surgery, Des Moines, Iowa, completed rotating internship and served as an OB-GYN resident at Metropolitan Hospital, Philadelphia, PA. Certified by American Board of Family Medicine after completing a family practice residency in 1982 at United Health and Hospital Services in Kingston, PA, Dr. Clearfield, since 1982, is a leading figure in family and integrative medicine, with graduate expertise in the areas ranging from cardiac rehabilitation, University of Wisconsin-La Crosse, to medical acupuncture, UCLA 1991, to age management and non-surgical aesthetic medicine, fellowship trained in diplomat status from the American Academy of Anti-Aging Medicine. Dr. C is the leading authority on cutting-edge medicine in Northern Nevada. In 2016, Dr. Clearfield's turned when, after meeting with several veterans who suffered traumatic head injuries while serving overseas, he connected the dots, recognizing several long-term maladies experienced by these soldiers as hormonal deficiencies from long-term neuroinflammation secondary to their TBIs. Research led him to study with Dr. Mark Gordon and certified by the Millennium Warrior Angel Foundation Traumatic Brain Injury Program. Dr. Clearfield's lectures on traumatic brain injury and hormone replacement in general have taken him to the OMED, the American Osteopathic Association Scientific Convention, NOMA, the Nevada Osteopathic Medical Association, the American Osteopathic Society of Rheumatologic Disease, and the American Academy of Anti-Aging Medicine. Dr. Clearfield is a Nevada delegate to the American Osteopathic Association's House of Delegates and the executive director of the American Osteopathic Society of Integrative Medicine. He hosts a weekly Tuesday night integrative medical webinar, and his latest projects include Endocrinology of Autism, The New Face of Weight Loss, Nearly Everything We Learned in Medical School Was Wrong, Progesterone After Hysterectomy, Yay or Nay, and Hashimoto's Thyroiditis, a conventional versus an integrated medical model from A to Z, tips, dips, and doozer sticks, what I've learned in 40 years as an anti-aging physician. Dr. Clearfield, it's wonderful to have you here with us today, and I'll let you take things from here.
Oh, thank you so much. Thank you so much, all, for having me here. This is one of my favorite topics, and it's usually a 4-hour lecture that I've had to whittle down to 45 minutes. So I'm going to be giving you the Cliff Notes version. Those of you who are old enough to remember what Cliff Notes were, the sort of the AI version of this talk. So we're just going to go right to the meat. I'm not going to go through the demographics and who gets TBIs and whatnot. We're going to get right into the heart of the matter. We're not going to be able to cover things like laboratory studies or treatment protocols, although I do have them at the end of the lecture, because there's just too much information to put in 45 minutes. If you like this, we can talk about that later. Since it is a CME course, I have no relevant relationships with commercial interests to disclose. Here are objectives. We're going to talk about TBI and psychiatry, neuroinflammation, the magnificent 10 hormones and how we connected the dots and their effects on behavior and mental health maladies and hormones that they affect. And we'll do a brief introduction to hormone optimization remedies, but I can't really do all of those topics justice in this amount of time. So what happens when at a traumatic brain injury? We end up with cerebral edema, cerebral hypoxia and ischemia, cerebral spasm, increased intracranial pressure, cell death. We get increased glutamate, which is your activating or agitating neurotransmitter. We get mitochondrial dysfunction and impairment of glucose metabolism, blood-brain barrier damage, excitotoxicity, and complement activation and inflammation and reactive oxidative stress. The 10 most common symptoms post-TBI include 1, fatigue, almost 100%, never say 100%, but almost 100% of the patients, excessive sleepiness and disturbed sleep patterns, inattention with difficulty concentrating. And I highlighted this because this is how we actually connected the dots between hormone issues and what we see with post-traumatic brain injury. Impaired difficulty switching between tasks, impaired memory, faulty judgment, depression and anxiety with panic attacks, and what we call treatment-resistant anxiety and depression, irritability, emotional outbursts, the diminished libido, and drug and alcohol abuse. And these are all new. These are all since the patients had suffered his traumatic brain injury. Symptoms that lead to neuropsychiatric issues are headaches, fatigue, and neuroendocrine dysfunction, visual disturbances, and vertigo. My first TBI patient that I saw, actually it was playing volleyball and got hit square in the right in the center of the head with a spiked volleyball, and 2 days later started having visual issues. So it was a coup contre coup type injury, and she had actually injured her optic nerve. Again, deficits in executive function. This was a key. Motor impairments, movement disorders, and seizures, agitation, aggression, apathy, sleep disorders, mood swings, pathological effects, anxiety, PTSD, and irritability, cognitive issues such as impaired attentions, slowed processing and illusions and hallucinations, new onset of substance abuse disorders, and challenges in communication, social cognition, and apraxia. So I'm sure most of these, if those of you who deal with these types of patients, this is nothing new. The psychiatric component to post-TBI, that there's a strong association between mood and anxiety disorders post-TBI. Traumatic brain injury and neurobehavioral alterations are the #1 contributing factor to long-term disability and the inability to maintain relationships and parenting roles. And chronic traumatic brain sequela is a template for psychiatric illness. And again, this is probably nothing new to all of you. These are some of the screening tools that we use, the PHQ-2 and PHQ-9. I'm going to show you that in a second. General anxiety disorder, 2 and 7 screening tools, the Epworth sleepiness scale, headaches and headache impact test, neurobehavioral symptoms, and PTSD checklists. I have all the references at the end the slides if you want to find them. So this is the PHQ-9. The PHQ-2 is the first 2 questions of the PHQ-9. If somebody could mute that, please, that would be a help. And so scale of 0 to 3, and of course, the higher the score, the more severe it is. And this is over just the last 2 weeks. And you can go through these checklists, and it'll give you a pretty good idea, and you can follow up on them. I'm going to show you a different one that we use, and we've used these on a monthly scale. This is the general anxiety disorder 7. It's recommended to do these at 3, 6, and 9 months with an initial evaluation. This is the one that we use. It's a little bit more compact. It actually takes into account pretty much all of the prior questionnaires that I do. We do it on a scale of 0 to 10. We put in the date the program started. We do this at the beginning. We have the patients rate their symptoms on a scale of 0 to 10. And we give this to them on the 1st of every month. We send them home with 6 of these, and they send them into us once a month, and we can follow their progress this way. So what are the consequences of long-term sequela of traumatic brain injury? So Axis 1 disorders, major depression, 26.7% of these are minor traumatic brain injuries, by the way, not the major ones or even the moderate ones. These are minor traumatic brain injuries. These are the ones that have loss of consciousness, if they have any at all, for less than an hour. Symptoms are usually, the initial symptoms gone within 24 hours. So again, minor traumatic brain injuries. Substance abuse disorders, 11%, phobias, paranoias, and panic attacks, 8.3%. Access to disorders, and this is where we shine. Borderline personality disorders, 34%. Obsessive compulsive tendencies, 27%. Keep that one in mind. That one's going to come back again. Paranoias and antisocial personalities. The psychological sequela, usually almost 100% of patients have fatigue. 50 to 77% of these patients experience depression within 1 year versus 20% of the general population. 44% of post-traumatic brain injury, minor post-traumatic brain injury patients have comorbidities, and 30% suffer what we call treatment-resistant depression. And these are patients that are on two antidepressants, 3 antidepressants, 4 antidepressants, and then they're on 2 or 3 or 4 drugs to counteract the side effects from the antidepressants. This study here by Silverberg, this was done in 2019, showed that there was no significant benefit of antidepressants for depression after traumatic brain injury. Pooled trial results showed antidepressants did not outperform placebo post-traumatic brain injury for depressive symptoms. And clinicians need to follow root cause etiologies, and that's what we're going to talk about today. So the pathophysiology, we have a brain injury. So we see traumatic brain injury on the left and post-traumatic stress disorder on the right. And in the traumatic brain injury circles that I travel in, post-traumatic stress disorder is considered a part of traumatic brain injury, that there has to be a physical and a mental component to both. So we get neuroinflammation, excitotoxicity, oxidative stress, which means excessive aging of cells. And we see that in both categories. We see behavioral changes as a result, deficits in executive function, memory, fear retention, and fear extinction. Sorry, I've developed a little cold over the last couple of days. With a brain injury, we get a primary insult of traumatic brain injury, cell death and cell damage. We get free radical release and cytokine release. And the cytokines that are released in traumatic brain injury are actually quite predictable, and here they are. Interleukins 1B, 4, 6, 10, 12, 15, 17, 18, 23, and interferon A and TNF-alpha. All of these are psychiatric disorders with studies done with these cytokine abnormalities in each one of them individually, the major ones at least. And the common denominator is interleukin 6 and TNF-alpha. So interestingly, we find it in post-traumatic stress disorder and traumatic brain injury, this high cytokine or inflammatory protein markers. So when my first patient came in, he was an ex-Marine. He'd been in a rollover accident in the Gulf War, and he came in and he came in to see me. He had no hair. He hadn't grown any hair in 20 years. He had a very sort of high squeaky voice. He had no libido. But the aha moment was the loss of executive function. So executive function deals with concentration, memory, getting things done, starting projects, finishing projects, multitasking, and curiously, obsessive compulsive disorders. That was sort of the key here to matching the endocrine issues with a post-traumatic brain injury. And again, executive function here is, again, task initiation, planning and prioritization, organization, flexible thinking, switching between tasks. Remember, that was one of the big symptoms I showed you earlier in the list, and completing tasks. This is executive function, and this is what happens. This is what gets lost in a lot of these veterans. And so our missing link, and if you think about it, a lot of things that happen in endocrinology that are sort of get muddled for years and years and years. If you give it a thought for 30 or 50 seconds, you would say, why didn't I think of that? It was kind of a V8 moment. So where the endocrine hormones are generated? In the hypothalamus and the pituitary, right in the center of the brain. And so if we injure it, the hypothalamus is only has 2 very thin nerves and no blood supply at all, and the pituitary gland has 2 very thin arteries that are easily injured with any type of head injury. And so clues to hypothalamic involvement is an elevation in growth hormone with a normal MRI, elevation or depression in prolactin, and we're going to talk about that in a few minutes. Low peripheral testosterone with a low LH-FSH, elevated insulin suggesting a metabolic syndrome, a TSH index of less than 1.3, and I'll explain what that is when we talk about the thyroid, syndrome of inappropriate ADH, and a history of blast wave trauma or blast head trauma. So the concept of neurosteroids came about in 1985 by a French researcher who discovered that hormones were manufactured regionally in the brain. That is, they were produced independently of the periphery, and they're produced and acted on by glial cells and neurons. So the brain makes its own hormones, and I'll show you in the next slide which ones they are. They follow the same steroidogenic pathway as the peripherally generated neuroactive steroids, but the brain hormones we call neurosteroids. They regulate the excitatory and inhibitory balance of the neurotransmitters, glutamate and GABA. They act as microhormones, and they fine-tune the peripheral macrohormones. Sufficient GABA, that's the calming neurotransmitter, levels relieve anxieties, reduce stress, improve sleep, and are neuroprotective, and they stabilize mood disorders. So neurosteroids they regulate the neurotransmitters, particularly GABA and NMDA. They suppress neuroinflammation and promote neuroregeneration. Failure of the neurosteroid system in traumatic brain injury results in erratic brain transmissions that's translated as and expressed as depression, suicide, anxiety, panic attacks, phobias, and psychosis. These are the neurosteroids, are the most important ones that are made independently in the brain. So pregnenolone, progesterone, allopregnenolone, which is probably the most important one, estradiol, progesterone, testosterone, and glucocorticoids. DHEA is also in there also. So this was a study done actually in 2011, and this looked at the concentration of neurosteroids in the brain, which is over here on the right, and plasma over here on the left. And these are premenopausal women here for plasma in the follicular and luteal phase. And you can see postmenopausal brain has way more progesterone in the postmenopausal and luteal phase than it does in the periphery. So you can see there's a lot more of the neurosteroid hormones in the brain, or they're supposed to be, than in the periphery. This is pregnenolone, which is the hormone of memory. And so this again was part of that sort of a breakthrough and aha moment. So when we have some sort of injury, we get a pain signals go to the brain. It activates the hypothalamus. We get gonadal releasing hormone, which activates the pituitary. On the left-hand side, or my left-hand side anyway, you can see corticotropin releasing hormone, which activates adrenal cortisol or corticotropin and releases cortisol, pregnenolone, and DHEA. In the pituitary, it is activated in the follicle stimulating hormone and luteinizing hormone. Stimulates the gonads to make testosterone, progesterone, and estrogen. And over on the right, we have thyroid releasing hormone, and that activates thyroid stimulating hormone to stimulate the thyroid to make T3 and T4. Activation of the hypothalamus and pituitary post TBI. This is just a schematic of which hormones are stimulated from the hypothalamus with the releasing hormones. This is just for your information. This is a prevalence of pituitary abnormalities post-TBI, and less than 3 months, 40% of patients have some sort of pituitary abnormality post-minor TBI. It dissipates down to about 32% post-TBI after 1 year. Most of the hormones that are measured in abnormal levels, either too high or too low, sort of even out by 12 months, except for growth hormone. Growth hormone abnormalities actually increase over the year versus the other ones that sort of level out and decrease. This is another schematic from the hypothalamus to the pituitary to the target organs. Just keep this schematic in mind when we go through each of the hormones and their symptoms. This is a chart of the percentage of abnormalities, of hormone abnormalities, within 24 and 96 hours of a mild traumatic brain injury. And And I have the reference at the end of the talk if you need it. And so over here you can see cortisol abnormalities, 50% decrease in cortisol within well, about 40% within 24 hours, and 50%. This is percent of patients, by the way, within 96 hours. Evening cortisol is much less. Reverse T3, if you don't know what that is, we'll discuss that in a few minutes. Also, more than 50% of the patients have a drop in reverse T3 after 96 hours. Prolactin, remember, prolactin is regulated by an inhibitory factor protein. So when we have a disruption with prolactin, we're going to get a rise in that. Sex hormone binding globulin, not so much, but look at testosterone, especially in males. 96 hours, almost 100% of these patients have some sort of testosterone abnormality in the total and free. LH, which is your luteinizing hormone, which stimulates your Leydig cells to make testosterone. Over 50% have an abnormality. FSH, which is stimulates your Sertoli cells to make testosterone from the testes, about 35%, and IGF-1, which is a proxy for growth hormone, that's your usable portion of growth hormone. Also, so within 24 hours, you can see that there are hormone abnormalities and changes. So we're going to go through some of the hormones. We're going to talk about some of the symptoms. I'll give you some tips on what to look for if we have. Further on, we talk about the laboratory studies. I can give you a sort of rough general idea. And at the end, I have a chart for a treatment protocol, just so you have at least something to look at. So testosterone effects on cognitive function. It aids in mood stabilization, motivation, also strength, energy. Testosterone deficiencies result in depression, fatigue, and suicide ideation. You can actually predict testosterone abnormalities and depression symptoms. So testosterone's at a total of 295 and free of about 6.0 will indicate at risk for depression, and a total testosterone of about 150, less than 150, the patients will be frankly depressed. That's for males. For females, normal should be about 30 to 40, but for males, depending on what lab you're looking at, it'll say, I mean, lab studies that are kind of useless. One lab will tell you 250 to 1100. Our goal for all men is about 700 to 900. And again, if we talk about laboratories in another session, if you like this and you want me back, then we'll tell you how we get to that figure. Everything is figured out. I mean, it's none of this is done by guesswork. So for females, normal is about 30 to 40. If we get a total testosterone for females of less than 12, they're at risk for depression, and less than 6, these are patients that will be frankly depressed. Testosterone attenuates those inflammatory cytokines. It increases interleukin 10, which inhibits pro-inflammatory cytokines, including interferon gamma, interleukin 3, TNF alpha, and GM-CSF. It protects against mitochondrial dysfunction. It controls neuronal excitability. It improves seizure control. It can act at times as an aromatase inhibitor, limiting estrogen, although usually it will increase testosterone by aromatase, or rather, sorry, it will increase estradiol by aromatase. And it helps maintain therapeutic levels of DHT, which is the active portion of testosterone. Testosterone affects the central nervous system, and testosterone levels are inversely related to depressive symptoms. Here are those figures that I gave you before. Traumatic brain injury leading to low testosterone, leading to depression, will lead to suicide. And as we know, it's the 10th leading cause of death in the U.S. and in the military. I don't need to tell you. You know, I think it's the last figures I heard one time 22 suicides per day in the post-military, in military ranks, and I've heard it's up to 26 or even higher. There's a direct relationship between low testosterone, depression, and suicide. If you have a patient who's been severely depressed and has had a head injury and they have suicide ideation, you must check their testosterone levels. Men are 4 times the risk of suicide than females. Suicide attempts are inversely related to testosterone levels. I got this figure from a lecture from University of California, San Francisco psychiatrist. He says the peak year for men for suicide is age 80 to 90, and then for females it's 50 to 60, and he attributed it to the loss of estrogen. And when I asked him why they didn't replace the estrogen in females, his initial answer, and this was about 10 years ago, was that they didn't know how to do that. The last time I spoke to him, last time I was, he gave the same figures. He told us, well, they're at least referring them out now. So we moved the needle slightly. Again, this is just a capsule snapshot, so we can cover all of the symptoms. We could talk all day about testosterone itself. The main point is that testosterone is not just for sex. In fact, testosterone is an anti-aging agent. Patients over the age of 60 that have adequate testosterone levels, and again, in our clinic, adequate is 700 to 900 total, and 50 to 110 for the free androgen index. So the free will live on average, independently of any other entities, 10 to 15 years longer than those that are not. So estrogen maintains cerebral blood flow to the brain. So early on, when we first started seeing men for low testosterone and it's with symptoms, we noticed that their estrogen levels would rise because of the aromatase activity. And the early consensus was that we would use estrogen blockers, particularly anastrozole, to get the estrogen levels to 0. Well, that quickly we found out that was quickly not tenable. Estrogen again maintains blood flow to the brain. It lowers the risk of PTSD after trauma. It modulates pain. It increases under stressful conditions, critical illness, and trauma. The psyche. It prevents cell death and acts like a growth factor. When we get estrogen levels very low, we were actually turning these men into postmenopausal women. Again, we didn't think about it. It used to be that if you had the original thinking was if you had high estrogen levels, the men would have heart disease, blood clots, and poor sexual function. Turns out almost all of that is not true. And it turns out that we were turning these men, again, like I said, into postmenopausal women. They were getting heart disease, they were getting dementia, and they were getting osteoporosis. And a male over the age of 50 who gets has a fracture from osteoporosis, the mortality rate in the first year is 37%. So they don't need us to help them along with this. Estrogen increases neurotransmitter quantity and function. It enhances nerve growth factor. It improves manual speed and dexterity. It provides availability of acetylcholine and preserves long-term memory. So, like I said, originally we would use aromatase inhibitors to get the estrogen levels down to 0, and that was really the wrong thing. We had guys driving their cars through the back of their garage into their kitchen, guys ending up out in the desert here and didn't remember how they were. A lot of them would put their keys in the freezer for some reason and not remember how they got there. I mean, had that. It got to the point where we were actually asking them those questions. We quickly, well, probably after a year or two, originally, so what we went on with the guideline were what I call the gym rats, the guys that were using steroids out of the gym because we didn't have anything to go on 25 years ago. So they were getting their testosterone levels to 2,000, their estrogen levels to 0, and neither of those turned out to be the right thing to do. So the consensus now, 700 to 900, like I said, total, and 50 to 110 in the free androgen index. So the free testosterone, and that takes into account the binding protein, sex hormone binding globulin, which it binds to testosterone as it travels through the bloodstream. We need to know what's the free part. So as far as the estrogens are concerned, we came to the conclusion that 15 to 25 was probably an adequate level for men. Anything over 40, we would lower it. That was up until about 3 to 5 years ago, when all this new information came out on osteoporosis and heart disease and even erectile dysfunction in men with high estrogen levels. So the only time we actually block estrogen now or lower it, we don't block it totally, is one, if they have some sort of symptoms of gynecomastia, two, if they have emotional lability, and three, some men, when their estrogen levels are high, and high is 50, 60, 70, and even above, if their estrogen levels are high, have better libido, better sexual function. Some of them are worse, so you have to ask. If they're having sexual dysfunction and they have high estrogen levels, we will lower them, but not all the way down to zero. So get it down. 15 to 25 is adequate. Anything under 40 is where we would go. But if they have estradiol levels of 50, 60, 70, I have one colleague who says he wants the men's estradiol levels to 150. I don't think that I don't want to go quite that far. As long as they don't have gynecomastia, emotional lability, or sexual dysfunction, we leave it alone now. We don't block we don't use any aromatase inhibitors at all. Estrogen is neuroprotective. It prevents neuronal loss in the CNS. It's the strongest predictor of acute mortality and poor long-term outcome. And it decreases the risk and progression of neurological deterioration in Alzheimer's disease, schizophrenia, and it aids in recovering from strokes and traumatic brain injury. Progesterone is the second half of the cycle, and this is a whole nother lecture. Progesterone will via 5-alpha reductase eventually morph into allopregnenolone, which stimulates the brain to make GABA, your calming neurotransmitter. And when we use 5-alpha reductase inhibitors, again for men, for hair loss or prostate issues, we can end up with seizures, anxiety, depression, and myelin repair. It's called the post-finasteride syndrome. You may have heard of that. And so it's important to preserve this progesterone, even in men. This is the steroidogenic pathway. The one that you see on the right is the one we always see with cholesterol converting to pregnenolone and then going to DHEA and your testosterone here and dihydrotestosterone. And it also, testosterone aromatizes to estradiol, and it also will aromatize or convert to estrone, which is the cancer-causing estrogen. But over here in the brain, pregnenolone converts to progesterone. Again, that same enzyme, 5-alpha reductase, to dihydroprogesterone, to that allopregnenolone. There are actually now synthetic allopregnenolone drugs that are available, and there's some kinks in them, though. Unfortunately, the patients have some of the patients end up with a sudden loss of consciousness as a side effect from these synthetic allopregnenolones, so they're not quite ready for prime time yet. But this would be, if we can get around that, that would be a big breakthrough in post-traumatic brain injury depression for these patients. At the moment, what we do for them is we'll give them high-dose pregnenolone. We can do 400 milligrams for 4 weeks, and then 100 to 200 milligrams. And then we also will use progesterone. And yes, we'll use progesterone in men, not high doses, 25 to 50 milligrams, to drive this pathway to make allopregnenolone. This is, again, just another, the alternative steroidogenic pathway. Progesterone, a decrease in progesterone results in a loss of memory, slowed thought, agitation, irritability, can't sleep, poor libido, headaches, short-tempered. And this is in men and in women. And we do measure progesterone levels in men also. Compare that to the symptoms of decrease in GABA, the calming neurotransmitter. And again, you can measure neurotransmitters in the urine, and you can see that they match item for item. There's long ago, I was an OBGYN resident, and we did what OBGYN OBGYNs do. We would do hysterectomies. We would give our patients synthetic estrogen and told them that they didn't need progesterone because they didn't have a uterus and they couldn't get pregnant when that was the only function of progesterone. Well, again, that turns out to be wrong. This is the end result. I have a whole lecture on progesterone after hysterectomy, and we go through all of these functions. 57 is a link to my lecture here. There's 97 references in that lecture alone. But the bottom line here is progesterone after hysterectomy, the pros to use it. It triggers catabolism. It relaxes smooth muscle. It's a sedative and an analgesic. It improves visual memory. It is immunosuppressive. It reduces neuronal loss and traumatic brain injury. It regulates that excitatory, inhibitory neurotransmitter balance, GABA and glutamate. It improves thyroid function. As an aside, for traumatic brain injury, it reduces breast cancer risk, memory loss, mood changes, impulse and aggression, stress, anxiety and depression, suicide ideation, emotional flatness, thromboembolic risk. It's protective against dementia, and it has a positive association with memory and cognition. There have been studies using IV progesterone, 8 milligrams per kilogram, within 24 hours of a traumatic brain injury. And in a phase 2 study, within 30 days, there was a 50% reduction in mortality of traumatic brain injury patients. Unfortunately, the phase 3 study that was done, for some reason, they reduced the dose from 8 milligrams to 4 milligrams, and it didn't work, and it's sort of fallen into disuse. But again, it would be like taking penicillin. You have a strep throat, and I give you 250 milligram penicillin pill a day, and then when that doesn't work, you say it didn't work. Well, you need 4. So that's progesterone. Growth hormone. Growth hormone is kind of controversial. It really shouldn't be. It's a 191 amino acid polymer. So I liken it to Legos. If you take a box of Legos, like say a car or a windmill, if there's 191 pieces in it, if you put it together perfectly, then you'll have the car or the box that you see on the side. Peptides, you may have heard of, are pieces of growth hormone for the most part, and there's derivatives now, but they started out as pieces of growth hormone. Growth hormone got a bad name from the athletes, and then of course the politicians got involved, and they gave a growth hormone a bad name. It is actually illegal via the FDA to prescribe growth hormone for anti-aging effects. It stimulates growth and cell reproduction. Symptoms of growth hormone deficiency are losses in concentration, memory, mental clarity, multitasking. Can you multitask easily or not? Can you start projects easily or not? Finish projects easily or not? Obsessive compulsive tendencies, and then more severe dark moods, paranoias, poor concentration, and anxiety. And growth hormone is where we made the link between head injuries and endocrine disorders. One of the major symptoms of growth hormone deficiency is loss of executive function. This is a comparison of traumatic brain injury symptoms versus autism. And as you can see, anxiety, stress, balance and coordination, eye contact impairment, again, executive function, seizures and impaired social interactions are disrupted. When we correct growth hormone deficiencies, we see a decrease in intensity of outbursts, hostility, paranoias, anxiety, phobias, and obsessive compulsive symptoms. We get improvements in verbal and nonverbal memory, cognition, mental alertness, and work capacity. This is a schematic of what we do. So we usually start out with what we call secretagogues. These are growth hormone peptides or pieces of growth hormone. And when we get through this regimen, if we're still not where we want to be, then we will start growth hormone. So usually I don't start growth hormone for at least 1 year to 2 years post-traumatic brain injury, unless they're extremely severe. And there's the doses there. This is, again, a different way of sort of analog. To be legal, we need to do a stimulation test, either a glucagon or insulin stimulation test, and if it's positive, it's considered to be positive for growth hormone deficiency. The thyroid is your gas pedal. It tells your body how fast or how slow to go. It actually consists of 4 hormones. We only deal with 2 of them because, quite frankly, we don't know what to do with T1 and T2. The number T1, T2, T3, T4 are the number of iodines attached to tyrosine. The T here in the T3 and the T4 is actually tyrosine, not thyroid. And that's the molecule or the protein that makes up the backbone of the thyroid molecule. T3 is your activated or your active thyroid molecule. This is what does the work. T3 drives mitochondrial ATP, myelination, and synapse formation. It modulates serotonin, norepinephrine, and dopamine tone. It stabilizes glutamine signaling. Adequate thyroid function is our fine-tuning and functioning of neural networks. Adequate thyroid function supports hippocampal neurogenesis and cognitive resilience after injury. Post-traumatic inflammation and stress often produces a low T3 pattern despite normal TSH. So our goal at TSH is usually about 0.8 to 2.0. If they have a low TSH, remember TSH, thyroid stimulating hormone, is an inverse. It is a detective. If you have not enough thyroid in your system, your brain will detect it and it'll tell your body, the thyroid, to make more. If you have too much, it will tell the thyroid to make less. The number that we get is an inverse. The extremes are usually about 0.4 to 4.5. 4.5 will be, or 4.7 or 4.8 or 10 will be flagged high. That means your thyroid function is low. So T3 is the part that does the work. If you have a high TSH, 5, 6, 7, and a low T3, this is indicative of a head injury. This is indicative of a inflammation and stress in the body itself. Hypothyroidism has strong ties to depression, apathy, and psychomotor slowing, post-traumatic brain injury. Low T3 correlates with poor neurological outcomes. Optimizing thyroid improves energy, speed, processing speed, antidepressant response. Hyperthyroid manifests as anxiety, insomnia, and agitation. So with the thyroid, we want to be Goldilocks, not too much, not too little. Low thyroid symptoms are dry skin, dry hair, fingernails crack and break, constipation, can't lose weight, cold all the time, tired all day long, and the edges of the edges of the eyebrows thin out. You can become a junior endocrinologist by looking at the eyebrows. The inner edge of the thighbrow, the inner third, for females is their estrogen concentration. The middle third, and for males, testosterone. So remember, teenagers have that unibrow, and as we grow older, the eyebrows, you get thinner and thinner, and they get wider and wider apart. The middle third is growth hormone, and the outer third is the thyroid. So loss of the edge of the eyebrows is indicative of a thyroid deficiency. And if you ask these questions, and first of all, hardly anybody asks the patients these questions. But if you look at them enough, you'll learn to know. You'll be sitting in a shopping mall watching people go by, and you can tell which patients have low hormone levels and low thyroid levels. So thyroid function and depression, total and free T4. Remember, T4 is the store unit. It can be up to 25% above the reference range with a low T3. So T3 is the part that does the work. There's also an entity called reverse T3. And reverse T3 is T3, the part that does the work, but it's been altered and it's actually upside down. Again, when we go into the thyroid lecture itself, we'll look at all of those structures and molecules. But for now, what we do is we do a free T3 to reverse T3 ratio. we take the free T3 and multiply it by 10 just so we get whole units. If it's greater than, I left out the multiply by 10. If it's greater than 2.0, that is a result of adequate T3 function. If it's less than 2.0, that's technically a cortisol abnormality. Reverse T3 is elevated 90 to 95% of the time with a cortisol abnormality. Now, it could be high or low, but you'll know that when you have a high T3, that you'll have some sort of cortisol or stress hormone abnormality. Thyroid function, as you can see here, 0.8 to 2.0, that's our goal for TSH. Free T3, 3.4 to 4.2. We address the antibodies. We see a lot of autoimmune disease these days, especially where I live, where we were downwind from where there was nuclear testing in the 50s and 60s. The fix here is a strict gluten-free diet, and I tell our patients this is a Judge Judy deal. It's a yes or a no. You're either doing it or you're not. Not a little bit, not 80%, not 90%. No, I'm not naive enough to know that they're going to go out on the weekends and go to a party, go to a wedding. But during the week, as strict gluten-free as they can be. The reason being, gluten is an irritant to the GI tract. 80% of the immune system is in the small intestine. So we see, especially with autoimmune issues, we see a high incidence of GI dysfunction, dysbiosis, and food insensitivities with autoimmune thyroid disease. And if we just go by the specialist, go to the gastroenterologist, they do the colonoscopy, they have an erosion or they have some irritability, and they'll give them pyrazole. Go to the endocrine guy. Well, there's nothing you can do for the thyroid antibodies. That's not true. Fix the gut. Anybody that has a thyroid abnormality, you'll have to do a deep dive into the GI tract. You have to look at their normal flora, GI flora, and the abnormal GI flora, and you have to look for bacteria, viruses, parasites, and candida, and H. pylori. And one of our favorite fixes, and again, this is a whole nother lecture, is low-dose naltrexone. Total T3 levels are inversely associated with cognitive performance. Those with relatively high total T3 show little impairment in memory, as well as visual, spatial, and executive functions. Those with low total T3 levels perform poorly versus healthy controls. Cortisol. So cortisol, stress hormone. These are the functions of cortisol and symptoms of low cortisol. When the patients wake up in the morning, they're tired. In the middle of the morning, they need something to keep them going. In the afternoon, they feel like they need a nap. By dinner time, they're exhausted. Later at night, they get a second wind. 8 o'clock, 9 o'clock, 10 o'clock. That's when they're most awake. That's when they have their best thinking. They usually have trouble sleeping after that, and there's usually sugar and salt cravings. Again, here's a deeper dive, and I did provide the slides for you. These are the effects of stress, again, cortisol. And you can see President Obama on the left in 2008 before he took office, and 2016 by the time he left. I mean, I can't show a clearer picture of this. Being president is stressful. The extremes for cortisol are Cushing's disease, which is almost high cortisol, low potassium, and Addison's disease, which is low cortisol, high potassium. The body is frail. Cushing's disease, the body is big. Severe Addison's disease, where cortisol levels are almost zero, is a medical emergency. These patients can be dead within 24 to 48 hours if they exhibit these types of symptoms. Cortisol levels and symptom severity are due to augmenting effects of cortisol and dopamine. Elevation of dopamine increases anxiety and panic attacks, and elevated dopamine levels decrease prolactin production. Low prolactin is a tip-off to treatment-resistant anxiety and depression. Level under 6.0, we see this over and over again in post-traumatic brain injuries. We measure prolactin levels on everybody. When they have low prolactin levels, typically we're looking for high prolactin levels, and that will happen, as I showed you, in the initial 96 hours. But this is long-term, 3 months down the road, 6 months down the road, 12 months down the road, 2 years, 5 years. We have measurements for up to 17 years post-traumatic brain injury in our database. and we show that low prolactin levels is consistent with treatment-resistant anxiety. And the typical antidepressants that we use, and even the atypical ones, actually don't work very well. You've heard of the term adrenal fatigue, and it's poo-pooed in the endocrine community. But what it is really is, it's not Addison's disease, it's not Cushing's disease, it's in between. So there is a disease pattern, and actually I actually mentioned it already, that is pretty consistent with moderately low but not abnormal cortisol, or moderately high but not abnormal cortisol. And again, these are the symptoms. I actually mentioned them just a few minutes ago: sugar and salt cravings, poor concentration, brain fog. Secondary symptoms are insomnia, frequent urination, poor circulation, depression, weight gain, decreased libido, again, brain fog, hypoglycemia when stressed, poor wound healing, and vertigo. Cortisol is balanced by DHEA. So high cortisol to DHEA ratio is an active depression. When we get low cortisol to higher DHEA levels, the depression lessens. This is a chart for the cortisol to DHEA ratio, and we get a 5 to 6 cortisol to DHEA ratio, 5 to 6 to 1. That's a balance. Anything greater than 8 to 10 to 1 is cortisol dominant, and we see chronic stress issues, cardiovascular disease, immune suppression, and increased catabolic issues. If it's less than 3 to 1, the cortisol is low, or you have elevated DHEA, and we measure DHEA sulfated, not just plain DHEA, and we can see adrenal insufficiency, congenital adrenal hyperplasia, or usually with DHEA supplementation. DHEA itself is sort of a mini testosterone. It builds and protects cortisol catabolism. It'll help decrease visceral and subcutaneous fat. It will decrease LDL cholesterol, improve bone density, improves insulin sensitivity. It was actually approved by the FDA in 1952 as an antidepressant. It's not usually used for that anymore, but it will balance. You have a highly irregular cortisol level, or somebody who's quote unquote stressed. DHEA for females 10 to 25 milligrams, males 50 to 100 milligrams will balance that out. It'll take about 2 to 4 weeks. Pregnenolone is the hormone of memory. Since I'm running out of time, basically just remember that. We measure this on everybody. 90 to 110 is our sweet spot. It doesn't always correlate with poor memory. So we always ask the patients before we discuss their lab levels, how their memory is. We will have patients that have pregnenolone levels of 10, 20, 30, and they tell me their memory is just fine. Usually I leave them alone. I'll have patients with pregnenolone levels at 95 or 100, and they say their memory is poor. We'll use a little bit of that, 30 to 100 milligrams. Pregnenolone is also measured, deals with learning, besides memory, and it correlates with cognitive performance, and it improves with replacement. Prolactin orchestrates lactation, but low prolactin levels will exhibit symptoms of chronic treatment-resistant and treatment-resistant anxiety and depression. These are the symptoms. I'm going to leave them for you in the slides since we're just about out of time for males and females. We talked about low prolactin levels under 6. Here are some remedies. So the medications, bromocriptine and cabergoline for low prolactin levels. There's some supplements and herbs that we use. So curcumin, leuconophorians, L-theanine, zinc, and chasteberry, especially low-dose chasteberry, 100 to 120 milligrams. This works well, especially in females with menstrual irregularities. Here's a chart of symptoms that correlate with all of the different types of hormones. Hormones that are involved in a couple of psychiatric illnesses. So hormones that are involved in depression are testosterone, growth hormone, DHEA, estradiol, thyroid, and vitamin D3. There are the cytokines that are involved with anxiety, and it's hormones that are increased with anxiety are cortisol, dopamine, epinephrine, T3, and free testosterone. decreased are allopregnenolone, pregnenolone, and progesterone. So you have some guidelines. Here's a chart of the inflammatory cytokines and the symptoms and of deficiencies and excesses with the different types of hormones. These is what you need. These are the questions you need to ask. This is your history. For estrogen, hot flashes, night sweats, brain fog, belly fat, memory loss, bone loss. For estrogen excess, estrogen causes cysts, and it goes in the sexual organs. So ovarian cysts, breast cysts, uterus we call fibroids, and gallstones are associated with estrogen excess. It's not unusual to have a patient come in with abnormal uterine bleeding, breast tenderness, you'll see that a little bit later, irregular cramping, infertility, joint pain, mastitis, fibrocystic breast disease, and they'll tell you, oh, I had my gallbladder out 10 years earlier. This is estrogen excess, and invariably, most of these patients have had synthetic birth control pills with overly estrogenated at some point in their life. Progesterone, the symptoms of low progesterone: agitation, irritability, can't sleep, poor libido, headaches, short-tempered. For testosterone, low testosterone, anxiety, depression, poor sense of well-being, poor muscle tone, urinary incontinence, vaginal dryness or erectile dysfunction for men, poor libido, poor sexual function, too much testosterone, oily skin, oily hair, acne, skin breakout on the neck and shoulders. Road rage is in there. I don't see that very often, even when we treat men with it or patients with it. We treat females with testosterone also. Blood pressure elevations and acne. For thyroid, I mentioned already, dry skin, dry hair, constipation, can't lose weight, cold all the time, tired all day long, edges of the eyebrows thin out. And also, I failed to mention, oral temperature never gets above 97.6. Cortisol, tired upon rising, needs stimulants in the mid-morning, needs a nap in the afternoon, exhausted by dinner time, a second wind after 8 p.m., sugar and salt cravings, and they nod off easily. Growth hormone, we discussed that a number of times, memory, concentration, getting things done, the ability to switch between tasks, paranoias, obsessive compulsive tendencies, dark moods, insulin, you know about, thirst, excess urination, abdominal pain. This is usually your diabetic symptoms. DHEA is sort of like testosterone. So DHEA, there's noise intolerance, and pregnenolone, there's light intolerance. So there's a distinction between those two. Low prolactin levels as treatment-resistant anxiety and depression. Here are charts of all of the functions and the symptoms. There's treatment protocols on the left. If you're not familiar with them, you should really do some more study on this before you take it on, but I wanted to give you sort of a complete picture here, and thanks a bunch. To let you know that on Tuesday nights, we've been doing it since 2020. We have weekly webinars. You can get in touch with me. We can get you on those. It's 5 p.m. Pacific, 8 p.m. Eastern. We have integrative medicine webinars every week, and we're always looking for speakers. And coming up next month, am I allowed to mention this? The Congress of Medical Excellence, December 4th to 6th in Reno, Nevada, online and in person. And this is integrative medicine, homeopathy, and integrative medicine research, 3 days. Here are the references. And it's over. So thank you all. And how do I get out of this? Stop sharing.
Thank you so much, Dr. Clearfield, for a very great presentation. We don't have questions in the chat box right now, but if you have any questions for our attendees, you can put in the chat box, and I will hand it over to Dr. Blvd to do a closing remarks or comments.
Yes, thanks, Dr. Clearfield. This is a superb lecture, very helpful information, and I really appreciate you truncating and fine-tuning what is normally a 4-day presentation down to 45 minutes. I know that was a Herculean task, but you did a superb job, and things were not frenetic. It was great. Thank you.
Well, thank you. There was a mention in there about methylene blue and traumatic brain injury. Yes, it's not a hormone. That wasn't the topic. But if you go on our YouTube channel, Clearfield Medical Group, we have a lecture on methylene blue, and we go through all of the aspects of it. And it's actually my highest viewed YouTube video, and it's Methylene Blue, the Clearfield Medical Group, and we have the charts like this. I always make charts the way I did here, because we always want to have you go home with something that you can use, put it by your desk and use it, references the next day, starting the next day. I've been around the block a few times, and we always want to be able to say, when your patients come to you and say, my doctor said there's no evidence of fill in the blank, we give you the evidence. So you see, I think there was over 100 references just in our 45-minute lecture here. So we extensively reference everything.
Dr. Clearfield, thank you for increasing our armamentarium with regard to TBI and the physiological and biological aspects of it, as well as the significance of hormones in many of these issues, especially with the TBI patients.
Thank you. If you want to know more, go into a deeper dive, I'm available. We actually have a video course that at one time was CME accredited, but it's not anymore. I won't go into the reasons why, but
Dr. Clearfield, before we end, there's one question in the chat box that I want to address. Male patient on hormone replacement, estrogen 3-XULN, is still no aromatase inhibitor.
Okay, can you mention that again? Male patient on hormone replacement.
Estrogen 3-XULN is still no aromatase inhibitor.
Yes. Okay. So again, this is new thinking. I mean, if you go on Dr. Google, and it'll be all over. It'll be all over there that you have to reduce the estradiol levels. That's the old thinking. This is new. This is within the last 2 to 5 years. I was taught that we always wanted to control the estradiol levels also. It was hard to change, but once I sort of made the break, it made a lot of sense, and our patients are doing a lot better. So the only time we'll use we'll reduce estrogen, use the aromatase inhibitors if they have gynecomastia in any type. Okay, including just breast sensitivity or breast tenderness. Doesn't have to be lumps or bumps. By the way, to get gynecomastia, you have to have an adequate amount of growth hormone also. If they don't have growth hormone, they're not going to grow breast tissue. So look for that too. With gynecomastia, you want to look at their growth hormone levels, or IGF-1, which is the usable portion of growth hormone. Number 2, emotional lability. Number 3, if they're having erectile dysfunction or sexual libido issues, and they have high estrogen levels. So 3 times the level. Unless you have one of those issues, I would leave the estradiol alone. Okay.
All right. Thank you so much again, Dr. Clearfield. Thank you everyone for joining us today. We hope to see you tomorrow for our pain webinars, same time, 1200, and the link will be sent to you for the reminders. Thank you all for joining us today. Have a good day.
And thank you all for having me.
Thank you, sir.